Very good morning to one and all. It's a great honor to present in front of such stalwarts. And I've been working on artificial intelligence at Nara Netralia. This talk is just in a gist to look at how artificial intelligence can rather simplify many of the things we do. The most commonly asked questions is the fact that artificial intelligence cannot obviously replace clinical acumen, but obviously in the long run, it is something which is already here. People say, is it the future? I normally tell them that this is not the future, it's already in the present. So what is artificial intelligence? There are two ways of going about it. One aspect is you're trying to look into parameters, create a database, utilize that to train the artificial intelligence, and then use that to predict whatever your research question is, whether it's predict progression in keratoconus, predict a type of procedure which would be suitable to a patient. There are two ways of going about it. One is looking at artificial intelligence using images. I think many of you might know that AI in diabetic retinopathy and images and fundus images and segmentations it's been happening for a long time. So how do you go about that is they use images, segment that into smaller segments, utilize those smaller segments, put it into an AI algorithm and use that to predict. Now, what my field of work is more on anterior segment. The challenge in anterior segment is it's quite difficult to segment images because of the lack of homogeneity. If you're looking at a topographer, the same grade of keratoconus might have different types of, parameters, indices, color patterns, and therefore it gets difficult to really segment that out. That is where the role of AI using raw data and raw data points is something which is important. Now, we use a lot of classifiers. I don't want to go into technicalities. We have something known as the random forest classifier. The main logic in all of this is there are learners which help in taking your data. So if you look at these points, these are known as nodes or decision trees, where each one of this is a parameter. So for example, if I'm looking at keratoconus, this can be Kmax, this might be an aberration. Which parameters picked up, it's again based on the data set which you put into the AI. The most commonly, types of classifiers you get is something known as a random forest, because it randomly branches into various variables. There is also something known as the support vector machine. There is also something which is known as, the neural networks. So we wanted to look at how, this is I think 3.5 years back, where we wanted to utilize some AI algorithms and try to decipher and answer commonly asked questions. The challenge obviously lies in building a database, and that is where it is quite painstaking. The first AI project took about 3.5 years. The basic fundamentals still remain the same. You're dividing it into a training and a testing data set. You're using a suitable model, and then utilizing that model you're trying to predict, right? So this is one of the softwares we use. This is known as an orange, where if you see, it's kind of easy to get used to once you start doing it. There is a file, there are various classifiers. It's about using permutation combinations of the data set. So running the AI is actually the 5% of the job. Building the database to be put into the AI model is something which is quite challenging. So a little bit on the journey on what parameters, how we looked at AI in various aspects of whether it is ocular surface, whether it is refractive surgery, whether it is keratoconus, is what I'll be speaking on. So this is the first project we had. You might have heard me speak on this, where we are using AI to predict progression in keratoconus. This was a challenge, considering the fact that there are multiple time points. So what we did is took out images, converted the images into raw data points, which included both curvature, pachymetry, aberration derived, and we utilized that into building an AI model. And in fact, it was quite accurate in trying to predict, which of these patients will actually progress. Now, the challenge obviously lies in the spatial or the time-dependent variables. Now, a patient might progress based on images, but when will the patient progress? That is something which we still haven't really overcome, and we should be doing that in the future. Now, what is also important to understand is that though these models are accurate, majority of these models are actually based on imaging and raw data points. Now, the second question is in terms of topographers. Dr. Sher spoke very well on the evolution of various instruments in screening and refractive surgery. But the challenge of current tomographers is it really does not dissociate the epithelium. It's under the assumption that the epithelium is regular, and therefore, many of the parameters we study, in fact, can be erroneous. And that is where we are actually missing the true picture. We should be ideally delineating and removing the epithelium. We also then moved ahead and built an AI model looking at the various epithelial parameters, okay? So MS-39, no doubt, is a costly device, but it is a hybrid device, which gives you the epithelium, delinks epithelium, gives you the stroma, and stroma is where we're actually supposed to be looking at. And interestingly, many of the parameters which helped in distinguishing whether it is normals, the very asymmetric eyes, so the form forestier, early ectasias, and the clear-cut keratoconus was in fact Bowman's or the stromal-derived parameters, and that are kind of validated our point that stromal mapping is something which is here to stay, and that is in fact where we're supposed to be looking at. Epithelium can be a masquerader, can be a confounder, and that is something which is important to remember. This is the second paper which we published, which looked at these various epithelial parameters. This was in the British Journal of Ophthalmology. Now, progression in keratoconus, like I said, it's not a diagnosis of just a pentacam. It is a clinical diagnosis, a diagnosis of the patient. There are so many other factors, age, gender, eye rubbing, there are so many determinants which we as clinicians also need to factor in addition to just looking at the various, the data which we see. And that is where we built our next, AI model which looked at risk stratification. Now, this is something which wasn't done earlier, but what we tried to do is plug in these various risk factors into it. So we moved ahead, one step ahead of the model which we've already published, utilized that, built all the risk factors, plugged in the risk factors which included age, gender, eye rubbing, the Ig levels, vitamin D and B12, presence of systemic allergy. And in fact, it is very interestingly, these are the parameters which were picked up. And that is something which as clinicians, we obviously are aware of, but the combination of the factors is something which we don't really, look into. That is something which is important. Now, I also wanted to go a little bit into eye pain. Now, dry eyes, no doubt, is the most common cause of patients presenting with eye pain. But there are so many other factors, and unfortunately, there is no common algorithm to all of this. And what we did is, we wanted to, again, so this is a combination of imaging, combination of systemic factors, combination of non-strabismic binocular vision anomalies, which is something which not many of us normally tend to look at when we are talking about eye pain. And interestingly, we looked at 300 eyes with eye pain, and these are the parameters which were picked up. And if you note, orthoptics or non-strabismic binocular vision anomalies was also up there as one of the parameters which were picked up. So, you're looking at multiple parameters, imaging, demographics, AI in those kind of scenarios is kind of very helpful in these patients. This is a project which is ongoing, which is kind of interesting for refractive surgeons, where there are so many things which help decide a patient whether they're going to actually choose a refractive surgery. And we wanted to go a little deeper. For example, if you're talking about the waiting time, if you're talking about the time spent in the clinic, insurance, source of referral, income, there are so many determinants. And this is something which we are almost done with the first phase, where we are trying to combine various factors which are involved when you're trying to look at patients who come in or walk into a clinic. And this, in fact, can help us predict which one of these patients are actually converted into refractive surgery. So this is still work in progress, and which should hopefully be published soon on how AI can help in even decision-making in surgery. So I think the journey has just begun. I would like to end. AI, like I said, is not the future. It is the present. There are endless ways on how you can utilize AI in anti-segment imaging, and this was just a brief on the work we have done at our center. Thank you again for the chance.
Thank you so much, Dr. Gairik. Any comments from Dr. Ramurthy, sir?
Yeah, nice presentation, Gairik. My question is, artificial intelligence, a lot of it depends upon machine learning, the kind of data that's being presented to it. Yes. We all use multiple different topographers, multiple different systems. The artificial intelligence system that's developed in your institution, will I be able to use it? Will it be applicable across different centers, or each center has to develop its own?
So if you're looking at tomographers, ideally it should be the same. So if I've built an AI machine learning data on pentacam, ideally it would be better if you also have a pentacam data. But you're looking at topographers, various indices. What we're trying to do now is build a data set of, say, for example, there's a grade 2 keratoconus. What are the parameters which are changed on the pentacam versus analogous parameters on the Cirrus versus analogous parameters in the Galilee. But the challenge is uniformity. Now, running the AI, like I said, is easy, but it is the data and the symmetry of the data. So if I put in data in a certain set of order set, when I need to validate it and I send it to your center, you also have to put it in that same order and data set. That unfortunately, or that rigor of creating a data set will stay. I don't think that's going to go because, you need to feed in the right things for the AI to predict the right way. So in terms of that, that is a limitation, but that is the reason why these models take a lot of time to come. It takes years and years to build a data set, and hopefully more automations or more algorithms should be built in the future which can, address those
So
issues.
similar systems will have to be followed.
Yes, yes.
But then one center's model would not work for the other one.
No, so what we've done is in the AI, so we have been validating this across multiple centers in the world in terms of trying to build a beta tested versions of our softwares. So what we have done is centers which have, say for example, the first paper I spoke on where we published on progressors in keratoconus. There are multiple centers in the world which have obviously a pentacam. Now our data set is obviously related to our Indian population. Now we have sent it across to Italy, to Australia, to Brazil, where they are utilizing the same way. So what we have done is train them on how you, create the data set and put it into the AI model. And now we are in a phase where multiple centers in the world are trying to validate whether the same indices are picked up in their cohort, in their ethnicity, as compared to Indians. Now, that is the next phase, which is a work in progress, will take time, but we have already started doing that, training people on how you do it and how you put it into an AI model. And they have started sharing results. It should be out soon.
But if a new investigative device comes, then it's like going back to square one, isn't it?
Yes, so see, we've used gold standard devices. I haven't built it on a Galilee, which not many people have. It is either a Cirrus or either a Pentacam. As of now, these are the ones which are most commonly
But
available.
that's for today.
Correct.
What about 10 years hence?
Yes,
You
so
would need
in
to go
those
through
kind
the
of
same
scenarios-
process again.
Yes, in those kind of scenarios, what we do is try to look at indices which corroborate. So for example, if an SIF and SIB on a Cirrus correlates very well with the IHA, IHD, IVA. So trying to look at which one of those parameters correlate can be a way of bridging that gap. But yes, no doubt, you will have to start over again if there's a new tool. Because AI is not going to predict in another device which it has not learnt on. That is expecting too much out of AI models anywhere in the world as of now.
Thank you so much,
Thank you.
Gairik, for a very interesting talk.